Okay, so hello everyone. Today's lecture is pretty easy as well. This one is integrated control of the cardiovascular system 1, and we're also just gonna focus on the learning outcomes. Gonna be talking about the skeletal muscle and then the coronary circulation. Okay, so first we're gonna start with skeletal muscle contraction. What happens when you have skeletal muscle contraction? Basically, here, when you're exercising, you're gonna have more blood flow through your skeletal muscles, and this blood flow, as you can see here in the graph, is going to increase. Also, you're going to have more capillaries. You're going to have an increased number of capillaries in the muscles of athletes. And when you stop exercising, as you can see here in the graph, it doesn't drop straight away to the normal blood flow. It stays a bit high, and then it just takes a while to just drop to normal blood flow. Anyways, control of blood flow in skeletal muscles. When you reduce oxygen during exercise, what happens is that your smooth muscle is going to vasodilate to let more oxygen reach your tissues. And what are these vasodilators? You've got adenosine, potassium, ATP, lactic acid, and carbon dioxide. Okay. Nervous regulation of blood flow. Basically, all you need to know from this slide is that even when you have nervous regulation, or like even when your sympathetic nerves or fibers are working to like vasoconstrict your blood vessel, even when they're working, if you have a reduction of oxygen, your basically your vessels, they're still going to be vasodilated. Okay, that's basically all you need to know. Here, as it says, but the thing is, the effect of the vasodilators and reduction in oxygen levels override the activity of the sympathetic fiber activity to vasoconstrict the blood vessels. Okay. Three main effects of the sympathetic stimulation: it increases cardiac output, it vasoconstricts, which basically increases arterial pressure. It also constricts the large veins, which increases mean systemic filling pressure, which also increases the venous return, which causes more cardiac output. Okay, so what happens when you're exercising? Here, the example basically shows us leg flow. Your legs are exercising, let's say you're running or something. What's going to happen? The vessels in your legs, they're going to vasodilate to let more oxygen reach the tissues in your legs. However, all over the rest of the body, you're going to have vasoconstriction, except for your brain coronary arteries, because they need constant supply of oxygen, they need constant supply of blood. However, all the other vessels are going to constrict to allow more blood to reach the legs and more oxygen to reach the legs. As you can see here, all you need to know from here as well is that mean arterial pressure increases during exercise. It's normally 20 to 80. Sorry. All you need to know from here is that mean arterial pressure increases during exercise. When you have a increased pressure difference, you're gonna have more blood flow. Mean arterial pressure also stretch the blood vessels and cause vasodilation. Here, it compares two conditions. Here, the first condition is that you're only using a few muscles, which basically causes the arterial pressure to increase. As you can see here, it says up to 170 millimeters of mercury. It says vasodilation in few muscles and vasoconstriction in the rest. However, in this athlete, he's swimming, so he's basically using most of his muscles, like a lot of his muscles. So his arterial pressure is going to increase by a maximum of 20 to 40 because vasodilation is going to happen in most of his muscles. And on the other hand, you're going to have vasoconstriction and vasodilation only in the muscle that you're using. Okay. Changes in cardiac output during heavy exercise. As you can see here, B is exercising, A is at rest. The mean systemic filling pressure increases, as we said before, and you're going to have a decrease in resistance and increased venous return, as we said before. However, if you guys can see the circle lined here in A and B, the guy who's at rest, he has this circle basically represents cardiac reserve, and the guy A, number A, whatever letter A, he has more cardiac reserve, while B has less cardiac reserve. So the more you exercise, the less cardiac reserve you're going to have. And this is important for the next lecture, but I'm not going to be explaining that lecture. Okay. Changes in cardiac output during heavy exercise. This also we've talked about. Massive sympathetic discharge, you're going to have less parasympathetic impulses, and have increased heart rate, increased mean arterial pressure, increased heart strength, local vasodilation, global vasoconstriction. Your veins are going to constrict, you're going to increase your venous return, and your venous return is going to be equal to your cardiac output. Okay, coronary circulation. So now we're done with the skeletal muscles. Now we're going to go to the coronary circulation. What are the risk factors for coronary artery disease? We've got A, B, and C. Not reversible, reversible, and partially reversible. So the not reversible ones are aging, male sex genetic predisposition. Reversible ones are cigarette smoking, which lowers your HDL. And what does your HDL do? It balances out the LDL, which is your bad cholesterol. HDL is your good cholesterol, LDL is your bad cholesterol. You need HDL to balance out the bad cholesterol. You're going to have obesity, left ventricular hypertrophy. These are all reversible. However, the partially reversible ones are cholesterol or triglycerides, saturated fat in diet, low HDL, also hyperglycemia or diabetes mellitus, which also causes low levels of HDL. Anyways, plastic changes in coronary blood flow during systole and diastole. When your heart is basically contracting, when you've got systole, what's going to happen to your coronary blood flow? It's going to decrease, right? So as it says here, reduce coronary capillaries blood flow because your cardiac muscle is basically contracting. It's going to constrict. While in diastole, increase coronary capillaries blood flow, you need more blood to get to your heart. So your heart is basically relaxing, and that's going to cause increased coronary capillaries blood flow. And just know that your coronary blood flow is 5% of your cardiac output at rest. Okay, here we have control of coronary blood flow. Remember, we had control of skeletal blood muscles or vessels. Here we have control of coronary blood flow. Also, myocardial oxygen consumption. If your heart needs more oxygen, you're gonna have, but also vasodilation. Adenosine related to lower oxygen. Adenosine, as we said, is a vasodilator, so it's gonna be increasing your blood when you have less oxygen. Nervous stimuli, you have sympathetic and parasympathetic. Your sympathetic stimulation, you've got direct and indirect as well. So your direct effect, the sympathetic, is going to basically release norepinephrine onto your heart itself, which is going to increase cardiac output. What does it act on? It acts like sympathetic. It acts on alpha adrenergic receptors, which are mainly epicardial, and it acts on beta adrenergic receptors, which are mainly intramuscular. For the alpha adrenergic, that causes constriction. For the beta adrenergic, it causes dilation. However, the parasympathetic, what it does, it releases acetylcholine, which basically it's not mentioned, but it says it releases nitric oxide, which causes vasodilation, but it is only a little effect. Like, it's a minimal effect by the parasympathetic. This is all direct. However, what happens in the indirect? In the indirect, what you're gonna have is that the sympathetic stimulation and the parasympathetic stimulation, they're gonna increase metabolism. Like, metabolism all over your body. You're using more oxygen, so you need more cardiac flow. However, for parasympathetic, you've got less metabolism, so you're going to use less cardiac flow. However, remember, the direct, it acts straight on the heart. Control of coronary blood flow also, these are the vasodilators, potassium, carbon dioxide, prostaglandins, whatever. All of these are vasodilators, and remember that they override the nervous system. So even here, they override the coronary nervous effects. Okay? Special features of cardiac muscle metabolism, energy supply for the heart. Oh, so basically here you need to know that your heart relies mostly on fat. Also, it uses glycolysis, which is anaerobic. Remember also adenosine, it causes vasodilation, whatever. Collateral circulation in the heart has a life-saving value. Okay, when you have myocardial when you have myocardial ischemia, what's going to happen to your blood vessels? They're going to get arteriosclerosis. They're going to be blocked, and blood isn't going to be able to pass through the arteries. So, as you can see here, when this happens, you're going to have anastomosis, which basically happens around 2 to 3 days post-occlusion. Anastomosis is basically when other arteries are going to basically take place of that artery that got blocked, right? Normal blood flow is restored within 1 month if collateral vessels develop atherosclerosis, or if they are not enough to cover the damaged myocardium. Cardiac failure is inevitable. That basically means that when you have a block over here, like at the start of the artery, which branches to a lot of other arteries, anastomosis may not be able to, to help that out, and you would get cardiac failure. Here we have causes of death after acute coronary occlusion. What happens to that spot that can't get blood to it? It's going to get decreased cardiac output. It's going to get... Okay, so what's going to happen to that spot, right? It's going to be dead at the start. When it's dead, it gets replaced with fibrous tissue. And that fibrous tissue causes fibrosis. And when you have fibrosis, khalas, that place is dead. It is gonna rupture. With increased blood pressure, that place is gonna rupture, and that is what happens after acute coronary occlusion. You're gonna have decreased cardiac output, you're gonna have pulmonary edema, fibrillation, and rupture of the heart. Coronary steal syndrome, this basically happens when, as you can see here, artery B is blocked, is ischemic, while A is normal. So the blood pressure in A is going to be higher than that in B. So a collateral, this is what a collateral is. It basically develops between A and B, and it helps blood flow to go from A to B to go to the ischemic areas to not make them die. Surgical treatment of coronary artery occlusion, you have the coronary artery bypass surgery, and you have coronary angioplasty. Here in the bypass surgery, what you use is basically a vein from the leg. You take it. I think we've already talked about this in previous lectures. But basically, you just take a vein and you make a different route for the blood to go through because the artery is blocked. Angioplasty is when you put basically a catheter in, and that catheter has a balloon. That balloon makes a stent, and that stent keeps the arteries open. And that was it for today's lecture. Thank you for watching.